Let's join Dr. Gary Levine for a discussion on renal disease 1.
And we're going to go ahead and talk about kidney disease for you. I have no affiliations or interests in organizations that would create any bias in the information that I give you today. And as a disclosure, I have two kidneys. I want to thank Dr. Fraboni from University of Minnesota, instrumental in the first version of this particular talk. What about the kidney? What does it do? It helps us to maintain extracellular fluid environment. It helps us to excrete metabolic waste, as we know, balance water, electrolytes, and acids and bases. The kidney also secretes hormones. Hormones that regulate systemic renal hemodynamics. Dr. Fernhaber gave us a little bit of information on that before. The renin-angiotensin system, erythropoietin, which allows our marrow to make red cells, and of course, our calcium and phosphorus regulation as well. If you want the most effective, cost-effective test to look at renal disease, it still is the urinalysis. We look for the big three. We look for blood, protein, and pus, essentially. We recommend that our residents typically do their own microscopic exams in addition to their dipsticks. How many of you do urine micros in your office? Very good, very good. Why do we say that? Because, as we heard before from Dr. Geiger, maybe you have a positive dipstick test for blood, and if you have no RBCs when you look, then think about hemolysis, think about rhabdo. Remember that a urinary dipstick positive for protein is only measuring albumin. You can miss Bence-Jones protein if you're not careful. What if that leukocyte esterase test is positive? Usually that's a UTI, but if you don't see you see white cells, but you don't see bacteria under the scope, think about urethritis with chlamydia, think about glomerular diseases. If they look like eosinophils, think about interstitial nephritis. Hyaline granular casts, usually normal. RBC casts are not. That's glomerular nephritis. If you see white cell casts, think about pyelo. Our first question for you. The Cockcroft-Gault and MDRD formulas both use age, sex, and which of the following variables determine or estimate GFR? Our choices are creatinine, ethnicity, microalbumin, and actual body weight. You voted for creatinine, and A, creatinine is the correct answer here. This two common formulas we use are Cockcroft-Gault and the MDRD, modification of diet and renal disease formula. You can always do an actual 24-hour creatinine clearance, but most of the time we rely on these calculations. If you look at the formulas for which you're not going to be held responsible on the boards, but note that they all use creatinine. They also have, at least in the Cockcroft-Gault formula, a modification for sex, and the MDRD for sex and ethnicity. On average, if you have a 70-kilogram man, his creatinine is 1, then his GFR is 140 minus his age. Tends to hold. Women, 0.8, 70 kilos, 140 minus age. For every time the creatinine doubles, you get about a 50% decrease in your GFR. Protein excretion is important. We measure that. Remember the old 24-hour collections? People carry the jugs around. They don't like to do that very well. We now rely on random spot urines. A normal being less than 150 in a non-pregnant patient, 300 in a pregnant patient. Anything over 3 grams, 24 hours, that's nephrotic syndrome. If you look at a urine microalbumin creatinine ratio, again, a spot urine specimen, less than 30 is normal. 30 to 300 is microalbuminuria. Over 300, macroalbuminuria. We're going to talk more about that in the next 2 lectures. It's an important concept. What about acute kidney injury, AKI? You used to call this acute renal failure, but it has changed. The prevalence in our country is about 1% in the community, up to 7% in hospital admissions, much higher in the ICU. In that ICU, if the person requires dialysis, that mortality rate typically goes up to 80%. So acute renal failure, dialysis in the ICU is bad news. We know that if we can identify and diagnose this early, we can hopefully prevent worsening and multi-organ system failure by paying attention to details in that patient's care. But with acute kidney injury, like we'll talk about later with chronic kidney disease, people don't die of uremia. They die of cardiac problems and infections. Remember, cardiac problems and infections. How do you diagnose AKI? It's based objectively on changes in GFR, serum creatinine, and urine output. The board may ask you those components. KDIGO, Kidney Disease Improving Global Outcomes, has criteria to diagnose AKI. As a minimum, if your patient's creatinine increased by more than 0.3 within 48 hours, or 1.5 times their baseline within 7 days, or a volume of less than 0.5 milliliters per kilogram per hour for more than 6 hours, that's minimal criteria for AKI. There's also different stages of AKI. Stage 1 is that minimal criteria. Stage 2 is where the creatinine increases by 2 to 3 times your baseline, and urine output is down for more than 12 hours. Stage 3 is a 3 times or greater increase in creatinine, an absolute increase of greater than 4, urine output that's even further diminished for a longer period of time. So much more severe there. So 3 stages for AKI. We'll learn there are 5 stages in chronic kidney disease later. Number 2 for you, most common cause of AKI is which of the following? Ureteral calculus with hydronephrosis, diuretic-induced volume depletion, ATN, acute tubular necrosis, or acute interstitial nephritis. Let's see if we can get 2 for 2 here. This is a tough one. Most groups do not get this. And you didn't get this either, but you were close. The answer is C, acute tubular necrosis. ATN accounts for 45% of acute kidney injury. Prerenal disease, including diuretics, about 21%. Acute on chronic kidney disease, about 13%. Obstruction, the various glomerulonephritides, are down further on the list. 75% of all AKI is either prerenal or intrarenal. Intrarenal meaning tubular, glomerular, interstitial, or vascular causes. Postrenal or obstruction is farther down on the list again. What about prerenal causes? That can be actual volume depletion, that saber-toothed tiger that we heard about from Dr. Fernhaber, or things that lead to an effective decrease in blood volume, or medications that reduce urinal perfusion. So volume depletion from bleeding or dehydration, including diuretics, including GI blood, volume losses and burns. Decreased effective perfusion from heart failure, shock, cirrhosis, for example. Tubular interstitial, glomerular, and vascular or intrarenal diseases, again, also are important, but not to the same degree. ATN, acute interstitial nephritis. Again, those are acute tubular interstitial diseases. Myeloma, tumor lysis syndrome also can cause AKI. Phosphate nephropathy. We no longer use sodium phosphate as a bowel cleansing agent for colonoscopies because people's kidneys got ruined. Chronic tubular interstitial causes, polycystic kidney disease, nephrocalcinosis, reflux nephropathy are also on the list. What about ATN, the most common cause of AKI? Usually it's due to hypotension or sepsis, ischemia, surgery, or nephrotoxins or rhabdo. When the patient develops AKI from ATN, there's initial rapid increase in the creatinine, followed by a maintenance phase where it kind of stabilizes. Then there is a marked diuresis with recovery back toward normal. There is no specific antidote therapy for ATN. It's supporting the patient and treating any underlying cause you can find. Acute interstitial nephritis, you'll hear that, as usually due to a drug or an autoimmune or infectious process. These patients have fever, rash, and urine eosinophils. The board likes to ask you about urine eosinophils and acute interstitial nephritis. You treat this by getting rid of the offending drug and supporting your patient. Maybe steroids are helpful. Speaking about allergic interstitial nephritis, which of the following drugs is associated with this? Carbamazepine, left over from Dr. Geiger's lecture, allopurinol, omeprazole, or fluoxetine. And you're voting for allopurinol, and B, allopurinol is the correct answer here. Good. Some common drugs associated with AIN, allopurinol, some of your beta-lactam antibiotics, sulfonamides, phenytoin, some of your thiazides, NSAIDs, and cimetidine. Intrarenal causes of AKI are uncommon. Think about them if you have fever, rash, arthritis, and findings in your urine of RBC casts or significant proteinuria. For those patients, you often need a nephrologist and sometimes a renal biopsy to determine how best to treat them. Think about glomerular diseases either being nephritic or nephrotic. Nephritic diseases show up with red cells in the urine, typically hypertension, fever, things like IgA nephropathy, post-infectious glomerulonephritis, HS purpura. Board likes HS purpura, by the way. Rapidly progressive glomerulonephritis. Vasculitides are nephritic. Nephrotic processes like minimal change disease, membranous nephropathy, diabetic nephropathy, probably the most common one there. Those present with protein in the urine, edema, as the prominent findings. Vascular causes include micro and macrovascular entities. Microangiopathic hemolytic anemia, for example, is a microvascular cause. Atheroembolism from atrial fib is macrovascular. Vascular disease can be acute, such as a vasculitis or thromboembolic disease or HS or hemolytic uremic syndrome, malignant hypertension, or chronic like hypertensive nephrosclerosis. Post-renal causes, this is obstruction. The good news about post-renal causes is they're reversible. Guy comes into your office with a big belly because his prostate is all plugged up and he's got a hugely distended bladder, his creatinine is 7. You put a catheter in and the creatinine starts to come on down. These people usually do quite well. Ultrasound's the best way to look at and assess what's going on. Think about urethral strictures, kidney stones, BPH, prostate cancer, retroperitoneal fibrosis, or pelvic neoplasms. We mentioned biopsy. Who gets a biopsy? Your oliguric patient, creatinines are getting worse. They have RBC cast. You think they have a glomerulonephritic syndrome. You're thinking about treating them with immunosuppressants or steroids. Then those patients may benefit from a biopsy. Question number 4. 81-year-old man scheduled to have a CT of his abdomen with IV contrast to assess for a tumor. Has type 2 diabetes, creatinine is 1.5. Which one of the following would decrease the likelihood of contrast-related nephropathy? Our options are oral acetylcysteine, twice a day, 24 hours prior to the procedure and the day of it, oral prednisone the morning of the procedure, acidification of the urine with ascorbic acid, being 24 hours before and continuing for 48 hours after, or use of hyperosmolar contrast medium. And you voted for the first one, and oral acetylcysteine before and the day of the procedure is the correct answer here. Contrast-induced nephropathy. This is due to iodinated contrast agents. It's a leading cause of AKI, generally reversible in most patients following a predictable time course. But it is preventable, and that's what we're trying to help. Avoid radiocontrast media in patients at risk for AKI, such as chronic kidney disease patients, diabetics, sickle cell disease, those who are dehydrated, and those who are elderly. So how can you manage them to decrease your risk? You stop all your diuretics, ACEs, ARBs, and metformin before your dye study. Hydrate them well with isotonic solutions. Alkalize, not acidify the urine. And then you can use acetylcysteine. Current recommended dose, 1,200 milligrams twice a day, day before and day of. Now, there is some controversy about this. If you look at the kidney guidelines, and we're going to see more of those next lecture. This is recommended, acetylcysteine. If you look at the American Heart Association guidelines for cardiac cath, they recommend hydration and alkalization of the urine. So there is a lot of controversy there. The data isn't all that great either way. There are a lot of drugs associated with nephropathy. There's a list for you to look at your bathroom convenience. But I do want to highlight a few of them. NSAIDs. Our nephrologists wear buttons with NSAID and a diagonal red line through it. NSAIDs are bad news. Lithium certainly can ruin kidneys. The combination of aminoglycosides and vancomycin. Amphotericol. There's a reason why it's called amphotericol. ACEs and ARBs in the acute kidney injury setting can be nasty. Diuretics and some of your chemotherapeutic agents. What about metformin? The PARI line for many years has been don't use it if the creatinine is over 1.5 in a man, 1.4 in a woman, or a creatinine clearance about less than 60 due to the increased risk of lactic acidosis. Our colleagues, however, in Europe and Canada are a little bit more lenient. They'll use it below 60 as long as the creatinine clearance is over 30. If you have a patient on enoxaparin for DVT prophylaxis, try to use it only if the creatinine is less than 2. Remember, nitrofurantoin requires good renal function to be effective. Allopurinol, if you're going to use that, remember to adjust your dose for the patient's creatinine clearance. Question 5. You're reviewing the lab findings of a 64-year-old man hospitalized with AKI. No history of long-term medication use. Renal function's normal, but now creatinine's 2.8. BUN is 60. The gravity 1.025. Some hyaline casts on the sediment, and his FeNA is 0.75%. Based on these findings, which one of the following conditions is most likely? Is this hypovolemia due to vomiting? Is it acute pyelo, interstitial nephritis, or obstruction due to BPH? What's causing him to be worse? Your answer is hypovolemia due to vomiting, which is my answer as well. And this is a question about interpretation of a FeNA. The board will not ask you to calculate a FeNA. The board is going to ask you how to interpret it. Remember, you calculate it by looking at urine sodium and creatinine and plasma sodium and creatinine, plugging into the formula that you all can download onto your cell phones. And the interpretation is a FeNA less than 1% is typically a pre-renal cause. Over 2% is ATN, 1 to 2% is usually a renal cause of this. But be careful in your interpretation. A FeNA less than 1% can occur if ATN is superimposed on chronic prerenal disease. It may not be less than 1% in a prerenal state if there's underlying chronic kidney disease. It can be over 1 if diuretics are used. So if you have a person on diuretics and you can't interpret a FeNA, do a fractional excretion of urea. Check the BUN and a urinary urea, and then you can interpret it. With early obstruction or chronic obstruction, it can be all over the place. Question 6. Systemic manifestations of acute kidney injury include which of the following biochemical disturbances? Hypokalemia, metabolic acidosis, hypophosphatemia, hypouricemia. Your answer is B, metabolic acidosis, which is the correct answer here. We're actually doing pretty good on these. It's a good group. You see a lot of electrolyte problems in AKI. It's usually the hyper is not the hypos. Hyperphosphatemia, hyperkalemia, typically hypercalcemia. Patients are dry. You see a lot of GI symptoms, anorexia, nausea, and vomiting. Hematologically, you tend to see almost a pancytopenia. There is hypertension, a lot of weakness and lethargy, and eventually encephalopathy, coma, and death. But we hope never to get that far. How do you manage AKI? Hospitalize most patients unless it's mild and easily reversible, and you know that. In the hospital, you collaborate with your nephrologist and other subspecialists, and you support the patient as best you can. Try to identify an underlying cause. If you can, certainly treat that, be it sepsis or heart failure or whatever. Make sure they're not volume depleted. Get good renal perfusion and adequate arterial pressure of over 65. You may need pressors to do that. What about the patient who has AKI and is volume overloaded? Well, you can try some furosemide. Doesn't work, you keep on doubling it, or you put them a drip, or you change to Bumex. Eventually, if they don't respond, dialysis will work for you. Avoid exposure to aggravating factors like contrast media, toxic meds, NSAIDs, ACEs, ARBs while you're treating AKI. Correct your electrolytes, prevent your complications, including nutritional deficiencies. If your patient is hyperkalemic, you can give them calcium gluconate, you can give them insulin and glucose, you can give them some albuterol to inhale or a bicarb drip. These all temporize things. And while you're temporizing, you reach for the K-oxalate, which you give orally or rectally. If that doesn't work and they're still hyperkalemic, then again, dialysis. If the patient has a serum pH of less than 7.2 or a bicarb less than 15, then we give bicarb IV or orally. Now, we know through the years that non-oliguric renal failure patients, those putting out some urine where the creatinines are going up, do better than those who are anuric. So in the past, we said, give them diuretics. If we can push out the urine, then we know they're going to do better. Well, they don't do better. In fact, they may even do worse. In the olden days, we used to give them low-dose dopamine, a couple micrograms per kilogram per hour. Thought that helped. Data is very clear that doesn't help either. Question 7. Patients with AKI, urgent dialysis is not indicated in which of the following situations? Hyperkalemia, refractory to medical therapy, not indicated now. Volume overload, unresponsive to diuretics. Metabolic acidosis, pH of 7.25. Uremic pericarditis. Where is urgent dialysis not indicated? Is not indicated in that patient with a reasonable pH in metabolic acidosis. So C, metabolic acidosis, pH 7.25, is the correct answer. Why do patients need acute dialysis with AKI? Metabolic acidosis, pH less than 7.1, unresponsive to bicarb, who are volume overloaded. Those who have uremic pericarditis, neuropathies, or encephalopathies. Fluid overload, refractory to diuretics, hyperkalemia, refractory to medical therapy, poisonings and intoxications such as ethylene glycol or lithium. To prevent AKI, vasopressors, make sure that you get that mean arterial pressure up. In hepatic failure, cirrhotic patients, don't do large volume paracenteses without giving them albumin back. Watch for GI bleeding. With cancer chemotherapy, prehydrate them and make sure they get allopurinol to avoid tumor lysis syndrome. Don't give them nephrotoxic drugs. Avoid radiographic contrast if you can. If you need to use it, we talked about how to do that before. With rhabdo, make sure they're well hydrated. Alkalize the urine. In surgical patients, adequate volume, hold your ACEs and ARBs. Patients with AKI are more likely to get CKD later. We'll talk about them next time around. You want to prevent that. In the last 4 minutes, we're going to talk about the kidney and the heart together. Now, Dr. Fernhaber is gone. We can talk about the heart in his absence. So which one of the following statements is true? ACE inhibitors enhance angiotensin II vasoconstriction of efferent arterioles. Angiotensin II inhibits the secretion of aldosterone and vasopressin. ACE therapy should be stopped if a 10 to 15% increase in creatinine is noted, or cardiovascular disease is responsible for up to 50% of deaths in renal failure patients. And you got D. D is correct. Cardiovascular disease responsible for deaths in renal patients, like we said before. The heart and the kidney are connected. Acute or chronic dysfunction, one or the other, affects the other one. In fact, in patients with heart failure whose GFR is reduced, for every 10 ml per minute reduction, mortality increased 15%. And patients, again, with renal failure, cardiovascular disease, responsible for most of their deaths. The National Heart, Lung, and Blood Institute has looked at the cardiorenal syndrome. I don't think the boards can ask you these types, but in case they do, type 1 is where acute heart failure causes acute kidney injury. They don't perfuse, AKI happens. Type 2, chronic heart failure causes CKD. Type 3, AKI causes acute heart failure. Type 4, CKD causes chronic heart failure. And type 5 is where other diseases result in both renal and cardiac dysfunction, like sepsis or diabetes. We talked a little bit about renin before. It is released by the renal juxtaglomerular apparatus when there's not enough blood flow going to the kidneys. Angiotensin 1 is then formed. Renin is a cofactor from angiotensinogen and angiotensinogen, converting into angiotensin 1. Here you see a little graph of how that happens in that pathway in the kidney. When you have angiotensin 1, it's then converted into angiotensin 2 by the ACE enzyme. The ACE inhibitor prevents that. Angiotensin 2 is bad unless the saber-toothed tiger is goring you. It causes vasoconstriction, aldosterone secretion, and sodium retention, and vasopressin release, which causes water retention. All that makes blood pressure go up and makes the heart function worse if you're at the wrong end of the Starling curve. So ACE inhibitors are good. They block the conversion of angiotensin 1 to 2. But because they block that, things back up behind them. So angiotensin 1, renin, and bradykinins go up. ACE inhibitors lower arterial resistance, increase venous capacity, decrease cardiac stroke work, and increase sodium excretion. All those are good in heart failure. They also enhance parasympathetic activity. Remember, the sympathetic activity causes your arrhythmias and sudden death. So enhancing parasympathetic activity helps to interrupt that downward spiral. Now, remember from what Dr. Fernhaber told you that ACEs, what they do is they constrict they dilate the efferent arteriole, therefore decreasing the pressure within the glomerulus. That decreases creatinine, increases flow through the glomerulus, but decreases pressure. So expect the creatinine to go up. It should do so less than 30%. Those people who go up a little bit, less than 30%, actually do better. Here we see the efferent arteriole. But if, in fact, that creatinine bumps up by more than 30%, then something's wrong. You probably ought to acutely stop the ACE or the ARB. Then think about bilateral renal artery obstruction, poor intravascular volume, or other forms of renal vasoconstriction. So we've done really well in this, actually much better than any other group has done in the course so far. So congratulations. I hope this is helpful to you on your boards, and we'll talk about chronic kidney disease after hearing more about pregnancy.